So let's see, now that I've got the second screen going, let's make sure I'm actually showing the correct one. Do you see my Osiris window?
See the database window, yeah.
Database window.
Yeah.
Now we see the
Okay,
viewer.
so great. So this case is not COVID, and it starts back last fall. And this is a radiograph when this patient was diagnosed with acute myelogenous leukemia. He underwent treatment, including a bone marrow transplant at that point in time, and unfortunately developed a relapse around this time. So he comes back in January. And this was his first CT in January, and I've got a whole host of CTs. And he was symptomatic, but wasn't really that impressed with this other than just, there's a lot of volume loss, and most of this is atelectasis. And of course, could he have a concomitant aspiration or pneumonia? Absolutely. There's some airways thickening. And this is one of those ones where, you know, the ID team, when they come down, they kind of know that answer, but it's not really that helpful of a scan. Here he is a few days later, and now you can see there's actually some more discrete central lobular nodules, you know, a few here. And I'm going to just go through the time course because things really change in the last couple of months. So this is like 10 days after that first CT. And now you can see there's still some atelectasis, maybe a little bit of volume on board, not as much volume loss here. But this really at this point looks like aspiration or maybe even some viral pneumonia. Nothing was positive back then. They did bronchs, viral panels, everything. You can see central lobular nodules, some ground glass consolidation, and this kind of evolved into a full-blown ARDS. So he had lung injury, was hospitalized for quite a long time. You can see a few days later, he's just developing more diffuse consolidation. And again, nothing has grown. You can see nice discrete tree and bud nodules here throughout in some of the areas that were previously atelectatic. So then he kind of gets better, but then he relapses again and starts undergoing a different chemotherapy regimen. And at this point is neutropenic, and this is where things start to get interesting. He has some fibrosis in the upper lobes that I think is just sequelae of the lung injury from the prior insult. But now you can see he's got a lot of central lobular nodules, and some of them have a little bit of fuzzy margins surrounding them. So we thought maybe a new infection. He wasn't having any sort of new symptoms outside of his chest. And then these things just kind of evolve. He's got more ground glass, more of these nodules. Any infections in particular you want to think about, given this appearance?
Still viral, including metapneumovirus.
Mycoplasma.
Yeah. No. Yeah, viral, everything negative. And it was this study when I was reading this or was discussing with my fellow. Actually, no, it's the one after this from just a few days ago. So it looks the same. The patient's doing worse. And it was between these studies that they did a bronch, and they also did another test. And this is the one I was looking at. You can see there's a lot more. I still think there's a lot more little tiny solid nodules. And I just kind of mentioned in passing to my fellow, we didn't even put it in the report, that with nodules, you know, one thing to think about would be strongyloides, hyperinfection. But this patient didn't have any GI symptoms. They didn't have any rash. They didn't have any eosinophilia. Granted, they didn't have much of a white count at all. But this turned out to be strongyloides hyperinfection. They got DNA, universal PCR DNA on a bronch, and their stool, ova, and parasites was positive. And it kind of, I still don't know what to do with these nodules, because I always thought the cases I'd seen before that they were more random. You know, maybe we're trying to make too granular of a distinction here. But this one surprised all of us, but the patient's on ivermectin and reportedly getting better already. But wow. No GI symptoms, no anything else. So it's good that the ID team still comes down, and they actually posed the question to us, could this be strongyloides? And I said, definitely, with that history, or with the positive test, it would fit, even though I didn't think it was in this context.
Yeah.
So I don't, because I one, maybe two cases of this. I think others have shown it, David in particular. I always thought that they were more random nodules, but if it's hyperinfection where the organisms are getting into the bloodstream and then I guess they end up in the capillaries, that in theory it could be more of a central lobular process. I don't know. What do you guys think?
The cases I've seen before of strongy have basically been ARDS, and not. I mean, I don't recall that there were discrete nodules at any point that I had image of them, and it looked at me as if there might be a little pulmonary hypertension going on here too. I was wondering if this guy with the central lobular stuff was maybe shooting something into his catheter.
Yeah, I know, and that was a question we had that, of course, yeah, I had way back on one of these, but no.
Okay.
So that
might have been strongy all along, including the early,
right.
Alveolar damage.
It very well may have been, yeah. So just that was a surprise.
Yeah.
And then this one I saw this weekend, and I'm going to need your assistance on this, I think. So this is an unfortunate patient who, she had a ground level fall and busted up a lot. You can see she has some pubic ramus fractures. She's obviously not well to begin with, chronically dislocated hip. She has this really comminuted fracture here. And so she was doing okay, I guess, after the fall and just receiving some supportive care, and then became hypotensive and unresponsive. And you can see that there's some retroperitoneal blood, and I'll show you more. She also has a right-sided chest wall hematoma, and there's a little bit of active extravasation from an intercostal vessel that I will show you more on the venous phase as well. But I want to direct your attention to the mediastinum. So she was unresponsive, ended up undergoing quite a bit of CPR. And my resident actually made a good pickup that noticed that there's this stuff surrounding the pulmonary artery and surrounding this branches of the right pulmonary artery, and then anteriorly, you can see the pulmonary vein is narrowed. And on the venous phase, you will see that this area it continues to blush. And first I was wondering, could this be some sort of hemangioma or vascular malformation that was just filling in with contrast there? Because this was just resuscitation after a ground level fall. I didn't think this was going to be some sort of vascular avulsion, and I'm not even sure exactly what vessel it is, but you can see on the, I think there's fluid tracking along into the right middle lobe in this adjacent area of consolidation. And so I think this probably is some sort of vascular avulsion in the mediastinum. I don't know what it is, if it's the pulmonary artery or if it's the pulmonary vein, or if there's a bronchial artery that's leaking in here. But I'm guessing it's from just pretty exuberant chest compression during CPR.
Do you think it could be in the pulmonary artery wall, a kind of, rather than aortic dissection, pulmonary artery dissection or something? It looks like blood, doesn't it? I mean, it looks like contrast.
Yeah, I think it is. I think it's active. I think it's contrast extravasating, and I don't know. Yeah, I don't know what space that's in. I was thinking it was more
I'll bet you
outside of a vessel, but
I wonder if it's in the adventitia of the pulmonary artery.
What does it look like on the non-con? Is it bright?
There's nothing on the non-con. That's why I was showing it.
Really odd.
Yeah.
I mean, the way it's hugging the pulmonary artery must mean that it's in some sort of a connective teeth around that artery. So maybe it's subadventitial.
Right, but you would expect there to, if it's a lot, you expect it to be high in attenuation on the non-con. I don't know. It's weird.
Yeah, I know. It's really weird. And unfortunately, the lady ended up passing away. They just went to comfort measures. Yeah, it doesn't look like a typical adventitial sheath hematoma that we would see with the dissection. It's just I don't know. It's really weird.
Narrowing the left, it's narrowing the PA or the pulmonary vein on the left. Too.
Yeah, the pulmonary vein's a little narrowed anteriorly there.
No, the other, yeah, all the pulmonary vein. Look at that pulmonary vein.
Yeah. Well, that's true. Yeah, there's hematoma in the mediastinum elsewhere too.
It's got to be some injury. It's just weird. It's not high density.
Yeah.
Was she severely, unless she was severely anemic, which she may have been, because
that's a good point. She was. She came in and her hemoglobin was like 2.
yeah. So then it wouldn't be high attenuation on the non-con.
That's a really good point, Seth. Yeah.
Well,
But,
the thing is,
because I first. Oh, go ahead, David.
well, it's bright, so it's got to be flowing blood to be this bright. I mean, it's got, this is basically contrast density, so that's flowing blood. It's not clotted blood. And so, I think there's a channel that is filling with blood here, don't you think? I mean, that stuff is bright. So it's like
I totally agree.
like contrast flowing in a false channel.
And I don't know, like it's inseparable from the pulmonary artery here, but
maybe it's a left atrial. Yeah. It could have been an atrial laceration. I mean, given that the attenuation of the blood is different in between, it looks like the contrast, is, I don't know, it's splitting hairs, but it looks more similar to the left atrium than it does and the left atrium can be injured between the spine and the chest wall with MVC. I don't know why it couldn't be injured with a really intense compression. But
especially a bunch of rib fractures and very friable bones to start with.
Especially given that the hematoma really is surrounding the pulmonary veins, I would assume it's some left atrial injury. I mean, it's academic, but that's what I would really assume. It's real stuff pointing out.
But I agree with David. The contrast is more along the pulmonary artery. I don't know, but.
And if you do it again in the mediastinal window, is there a fair amount of generalized mediastinal blood about all those structures?
Yeah, I think as Seth was pointing out that yes, there are a lot of areas of just fat stranding blood surrounding the other pulmonary veins, narrowing the left inferior pulmonary vein there.
Yeah.
I wonder if it's in the transverse and oblique sinuses. I don't know if it's a weird case.
So
okay, before you go on, just at that level, if you look at just in front of the spine, if you scroll a couple back and forth in front of the spine to the right of the aorta. Just go the other direction again. Other direction. Keep going.
More inferiorly?
Yeah, keep going. Keep going. I thought I saw.
We got some nice smoke in the aorta too.
Just scrolling the other direction slowly.
I thought I said something too really quickly, but it might have been.
I saw another area of blood extravasation.
That might have been a bronchial crossing, but I couldn't.
Keep going.
Yeah, there are a few little bronchial arteries. Yeah.
Keep going.
And then you've got some atelectatic lung.
Yeah.
Yeah. Also, I'll share this one with you guys so you can look. I don't know.
Autopsy.
Yeah, I don't think they're going to do one, unfortunately. So this is a quick one.
The sheath?
What's that?
You think the contrast was in the pulmonary artery sheath?
That's what David was thinking. I'm wondering. It just looks a little different than what we typically see with shared sheath hematomas with dissections. And as Seth was pointing out, there were some along the pulmonary veins, more generalized around the left atrium. I don't know. I was thinking it was more in the mediastinum, but how it got there maybe was from the pulmonary artery, from the adventitial sheath.
Yeah.
I don't know, but this is a quick one and just a nice radiograph case. We're still doing procedures, especially emergent ones. You can see this patient has an intra-aortic balloon pump, and they underwent an emergent coronary artery bypass grafting. And one of my fellows saw this on call And you can see they've already closed up the chest, except there was an incorrect count of instruments here. And one of the nice things we do, this would be easy to overlook if you weren't, given that history. One of the nice things that we do, and I don't know, I think it should be done at all institutions if it's not, is they will take an operative or a radiograph of whatever is the missing thing. So in this case, you can see it's a sponge with a radiopaque marker on it. And so, here it's nice when you're able to compare to it like this. And you can see that the sternal wire configuration will change after they have removed that. So they had to go back in. They're still in the OR, but had to open up the sternal wires again. I'm not exactly sure why they had closed up before. They had, done the sponge count, but you see between the two clearly that they had to go back in. And let me get this. So you can see the different configuration of sternal wires. So other things still happening these days, including retained sponges. And of course, now the intra-aortic balloon was too low.
That's very
All right, I'll
handy.
show one more.
They give you a picture of what they're looking for.
I totally agree. I think it's been a big help. And I think for stuff like that, like in those cases, there's so much stuff overlying the chest, it's easy to blow by that if you're not cognizant of what you're looking for.
Right. I would have blown that off the pacing wire or a part of a intrathecal pump or something like that. Epidural pump.
Yep. I totally agree. All right, this is for Howard mostly, and I know we have some new viewers on here. This is one of the best examples of pulmonary edema I've seen in a long time. This was patient previously, then a month later. When you see something this severe, I've seen a few cases of lymphadenopathy carcinomatosis look this extreme, but this was pretty rapid. He was in AFib, and I'll show you the CT because I think this is one of my best examples of the septal lakes that we've had. You can see there's some areas where it looks a little bit more nodular, almost sausage-like in the lung apices, and this is just all septal thickening. So pulmonary edema doesn't have to be completely smooth septal thickening, as we've seen with a lot of these cases of the so-called venous lakes or septal pearls or whatever the original description was. You can see some of these areas undulate a little, and just a lot of peribronchial cuffing, effusions, and then even these lymph nodes. I think some of it is just congested lymph nodes. I don't remember what his underlying story was, but one of the better examples I've seen in a while.
Yeah,
like some of these areas, a little bit of a lymphatic pearl there.
You made an important observation, Travis, that lymph node enlargement is very common with lung edema. It makes sense. There's all this fluid draining, and not to get alarmed about it.
And they tend to be low attenuation in that setting too. They're often and smudgy. They don't have sharp borders.
Yeah, and kind of boggy.
Boggy, yes.
Yeah. So.
Okay, excellent.
Just congested, wet nodes. All right, I'll stop there. Thank you.
All right, Seth.
Right.
Good. Glad you could join us. Do you have any cases?
I do.
All right. There you go.
Okay, so lots of CTs. You can see a guy coming in. First CT, I'll just say, is relatively normal. Second CT comes in, has these little faint ground glassy things, and then soon after develops this pattern of lung injury. I mean, you could be thinking about what you think the diagnosis is. A lot of peripheral stuff, peribronchovascular consolidation. Kind of over the next few months, or sorry, next few weeks, develops this pattern that, the classic reverse halo sign, because this is all organizing pneumonia. Anyways, the point being is that, and then it progresses, gets better, and resolves, and now he's left with this. So I see the case where he's left with this residual fibrosis. And whenever I see this pattern of just residual peribronchial fibrosis, you know there was some pattern of or some incidence of organizing pneumonia or some acute lung injury. The point being was that this is not COVID. Here it looks like COVID because that's what has been described, and even here. And if I told you these CTs were taking, each one was 4 days apart or 3 days apart, you'd be like, yeah, it fits for someone who had lung injury from COVID and then did actually okay. But this was actually nivolumab. So this is just a nice progression of organizing pneumonia, acute lung injury, organizing or with subsequent organization, and then fibrosis over many months. We're seeing the same. So here it is. This is first started August 2017, and this was the most recent study. But the injury kind of ended in April 2018. So about a 6-month period, 5-month period. And really the main injury and starting to organize and heal really in a 3-month period or 4-month period. The point of this is just to say what we're seeing now, it's the same process. It's just much more accelerated because of the extent of the injury. But the lung goes through the same process trying to heal itself from this injury with these start of some injury, rapid kind of extent, subsequent organization, and then healing, and then fibrosis.
What was the agent, Seth?
Nivolumab.
Slowly?
I think it was, I can never pronounce him, nivolumab?
Okay.
Yeah, nivolumab.
This is a cool case because I had just never seen this before. Let's see if I can load these. So this is a patient, did the load both studies. So not a hard diagnosis to make on the chest CT, big type A dissection. You can see that the left atrium isn't very happy, that there's this large, hemopericardium. When you start seeing compression of the left atrial structures, you know you're in trouble. The nice thing about this was, I'll show you, they also got a CT of the head and neck. And for anyone who wanted to know what jugular venous distension looked like, this is basically jugular venous distension. So this guy had such bad tamponade from his hemopericardium that his jugular veins they're actually developing a blood fluid level or fluid blood level or hematocrit level because the blood can't even get back to the heart because the pressures are so high due to the tamponade. So I never really understood what jugular venous distension was until I really saw the CT and said, oh, now I understand. When you have jugular veins literally pushing out through the skin, kind of giving you this from the tamponade. So I thought that was really neat, kind of seeing physiology in action.
Did it prompt like kind of an emergency pericardiocentesis?
Oh yeah, absolutely. They knew he was in. From my understanding, they knew he was in tamponade pretty early on. But yeah, no, that right after the CT, they went ahead and drained it. So, something we get in conference, we do a weekly CTEF conference, and I think I've shown cases before. This is just one of the nicer examples, and we get a lot of stuff sent to us, and we have a lot of cases that are clearly CTEF, and then we have a lot of cases that are, a little bit interesting. And you can see this case came in and has these peripheral kind of ovoid or lentiform clots along the PAs, and the question is, no clot, and the question is, is this in situ thrombus, or is this from bad pulmonary hypertension, sometimes usually type 1 PAH, or is this type 4 PAH, i.e. CTEF? And it can be hard to differentiate. This is one of the cases that I think was one of the more pronounced examples that we determined to be in situ thrombus. And one of the ways that we kind of get to that distinction is that it's very, very rare. And I don't know if we've seen a case where we start to see this PA calcification, when you start seeing PA calcifications for whatever various reasons, people have different reasons or thoughts about why it develops. For me, you see it in systemic pressures, basically, and the vessel starts undergoing some atherosclerotic disease you get these smooth muscle cells that proliferate in the intima, and they release an osteoblastic-like factor that leads to proliferation of calcification and other stuff. And I think that when you start seeing this outside of the thrombus, that you're, in a pretty good, you're probably dealing with type 1 PAH and not type 4 pulmonary hypertension, which again is CTEPH. So this is just a really pronounced case of, and again, you can see the layering intimal calcifications of in situ thrombus. At least, and unfortunately, it's really hard. Because we don't take these patients to surgery, we don't get any path proof. But the other thing, does this one have it or does she doesn't? She doesn't have any of the mosaicism. But anyways, I don't know if you guys have any thoughts on that or any comments.
Didn't really, she had occlusions. Did she have occlusions farther out? Not really.
No, nothing else.
Really like occlusive disease.
No, she has no occlusive disease. She has just this layering. Yeah, unfortunately, it drives me nuts. We get these studies from outside, and somehow there are people out there that somehow think you can diagnose PE on 3 millimeter thick slices. But there was no evidence on this or CT direct catheter angiography, which all the patients undergo here, of having distal occlusions.
I think that helps too with the diagnosis.
Yes, 100%, 100% helps.
So if it's in situ thrombosis, do you have a feel for what the etiology of the pulmonary hypertension is? Because I've read about in situ thrombosis in pulmonary hypertension that is a consequence of a chronic left to right shunt as the etiology of hypertension.
No, it's very interesting. So if you read the papers, a lot of them say you only see calcification in this degree of pulmonary hypertension, this severity in long-standing shunts. I actually, personally, from what I've seen here and prior to that, disagree with that. A lot of people with just really bad type 1 pulmonary arterial hypertension, not the chronic, I know congenital heart disease is now part of that, but patients with just the either idiopathic or the genetic forms, I've seen more calcification in them than I have the patients with uncorrected shunts. But the point is it happens in both. I have cases with both uncorrected congenital heart disease and ones with just type 1 PH for other reasons. But the literature does say it's more common in people with uncorrected congenital heart disease. I just have not seen that in my own personal experience.
I think, I would say the one time I have not seen it though yet is with meth users. And I think it's probably just that whatever the cause is, it has to be really long-standing. And those patients, as a group, seem to be ones that the pulmonary hypertension comes on pretty quick and they do poorly.
That's a good point.
But I agree with you, Seth. I've seen it with congenital heart. Yeah, I've seen it with congenital heart disease, and I've seen it with other just idiopathic or familial group 1. But it's, I don't know if I've ever seen it in a child. It's something that has to be around for decades.
And I agree. Most of these patients that we see, and we have some people maybe 40-ish that present with this, but most of the people are much older. I think this was a 65-year-old gentleman. And I agree. I think it has to be there for a long time. But I think I showed a couple of weeks ago, someone developed actually in situ thrombus very quickly. I don't know if you guys remember that case. It basically developed over a 2-month period. So I used to think, had to be on chronic, but we have cases that develop very, very quickly. So
I think, Seth, one of the arguments here against this being kind of Eisenmenger's or related to a chronic left right shunt is that those people usually have a very large pulmonary artery because the shunt, long before they got to severe pulmonary hypertension, the shunt was already expanding the pulmonary artery. So before they get the Eisenmenger's physiology and start to reverse their shunt, they've already got pretty dilated PAs, and the dilation in this case is pretty modest.
Yeah, and also I have to say, in most cases where there's congenital heart disease that's bad enough to cause this pulmonary hypertension, you know, you should be, you know, I think you can usually pick up a clear defect, even though it's a non-gated CT. You know, given the difference in contrast attenuation, you pick up a big PDA or a big ASD or VSD or something, or at least suggestion of it. But yeah, I agree. The ones that I see with long-standing shunts have, from congenital heart disease, usually have quite massive pulmonary arteries. All right. And then last case, I don't remember what this is. Oh, this is a scary-ish case. Let me just sort this out. Oops. Okay. All right. 1 second, guys. Sorry. So this is a person who, young patient, underwent placement of a defibrillator. It looks fine here and looked fine here, but then the lead kind of flipped from kind of heading medially to laterally, which I don't think, you know, it wasn't seen or commented on. And then it kind of went down inferior. Around the point of this chest x-ray, she actually came in with this chest x-ray, which again, this was a few months ago, having some chest pain. I had nothing. This is a few days later, and now this is about a month later with continued chest pain. And you can see the change in the direction of this lead. I don't know what that is, I'm sorry. And then you can see in the most recent chest x-ray, the lead has this kind of very inferior strain. This is the right atrial lead, a very strange kind of position. And we have a lateral somewhere else, but I won't dig through it for the sake of time. So here is the finding on the CT. So this, unfortunately, the right atrial lead actually perforated outside the right atrium. And the main finding, well, and unfortunately it was missed on CT too, because, you know, just a lot of people weren't looking for it. It's not a gated study, but you gotta, anyone with chest pain with a lead, you gotta be just always look at the tips of the leads. And this thing had gone outside and burrowed through, and you can actually again see the progression on the radiographs, and actually perforated the right atrium and was the cause of the, and she actually had a decent sized pericardial effusion after placement, which then got better, but with continued chest pain. So just a lead perforation with changing morphology of the lead on radiograph over a few weeks.
Seth, was her pacer, was there any suspicion that her pacer was malfunctioning or the impedance was changing?
You know, I have to look at the notes because most of her visits were ER visits, and they were simply like, I have to look because most of them were just ER visits, and they're like, you know, you're fine, go, you know, nothing, your x-rays shows a big heart, but you otherwise look fine, and ECG is normal, go home.
So she wasn't having any, so the presumption is she wasn't having any arrhythmias or, you know, bradycardia, thing that tipped them off that it wasn't working, because a lot of times they'll specifically ask us to evaluate the lead positions.
Yeah, and we have a woman who specializes in this here, complex lead extraction. We do these lead extraction CT scans, which are fun to say the least, looking for lesions of the pacers along the SVC and stuff.
Okay.
I can't, right. Anyways, I'll have to look at the notes, but my understanding is they were not aware of any malfunction,
so just pain.
Yeah.
Yeah, that's interesting, because the ones I've seen perf, they may usually there's something wrong with the lead.
Leads, yeah.
And I've not seen someone present with pain, but I guess it could cause a pericarditis.
Yeah, no, and she had they put it in, I think it was okay, and then around the first, I have to look at the notes again, but around the time of the first chest x-ray when she had pain, but the lead was in place, she had developed a smallish to moderate-ish per echo pericardial effusion that then got better, and they thought that maybe she just had some pericarditis, but it was actually a perforation.
Okay. Yeah, that's a great example of that. Yeah, I've not seen a right atrial lead ever pointing down. I think that's
Yeah, no, exactly.
Because sometimes this, they come to our we see their imaging and they have no comparisons because they present to the emergency department or they're in town visiting or something like that. And yeah, anytime I see one pointing down, I always
no, down is the flip from left to right was weird. But I'd be like, okay, it's just flipped. Like here was one direction, then it flipped laterally. That still would kind of get me a little concerned, but I'd be like, okay, whatever.
Put them up side by side. I'm curious if the tip was in the same place or if because sometimes they just if the lead's flopping around.
Yeah, that's what and that's what I just assumed. It was the lead flopping around.
Yeah. If you show the very first one where the left atrial appendage lead has a curve from posterior to anterior, if you have a lateral projection for that.
You know what? I have a lateral on one of these where you can see this is the first. I have a lateral on one of these where you can see, and I don't see it on here. I have it definitely downloaded. Maybe one of these that's not. It may be this one that's corrupt or something. But you could see on the lateral that the lead definitely went from having a normal look on the lateral with that tip pointing up to now having a very downward curve going inferior. It was very, very odd. But here are, sorry guys. So here is the progression. You can see kind of, if I get the windowing right, kind of going and it's towards medial and then flipping lateral, still heading down, and then must have just burrowed through the wall. And I'll have to find that other lateral because it went from flipping up and then straight down.
But it's too far. It's too far anterior there anyway. Its course is wrong lateral view. So Jeff, normally when the lead is pointing down, it's loose in the right atrium.
Mm-hmm.
That's right. Go down into the inferior vena cava, but this was too far anterior on the lateral.
Right.
Lateral is really
this is very abnormal. This is dramatically.
Yeah, because the right atrium does not come that far anteriorly. So
it's very this is bad.
I'm saying if you just have the frontal view, so a lot of times you get a portable because they come in with chest pain, so they don't get a 2 view.
But your point is right. Someone asked me to look at this case on the CT and the chest X-rays just to give a second opinion, and the inferior pointing lead, I said that's bad.
Yeah,
I have not. That's just a weird.
Okay, excellent. Yeah. All right. Anyone else have a case?
I have a few.
I'm sorry. Who was that?
I have a few, Jeff, but I can wait until the end too.
Oh, you can go ahead.
I'm like Peter.
Okay.
I have a case also, but I think I think Peter can go first if he wants.
Oh, okay. I can
Doesn't
do
matter.
that. Why don't you show yours, Brian? Then because I already gave the control. And
Oh, okay.
Repeat
Let me. Sure. Okay. All right. Can you guys hear me? Okay.
Yeah, and I can see. It looks like a PET scan.
Excellent. So this is a lady came in with this CT. So you can see this anterior mediastinal mass. You can see a mass in the right lower lobe, right next to the fissure with fissural retraction. You can also see there's right hilar adenopathy. This patient went to bronch and EBUS, and the right hilar node came back as dedifferentiated adenocarcinoma. And then the question is what to do with the anterior mediastinal mass. The patient also had a PET CT. You can see on the PET that there's pretty similar levels of uptake in the anterior mediastinal mass, the right hilar lymph node, and the right lower lobe mass. I think the numbers for that were 2.5, 3.5, 3.8. It's not a whole lot different. There was also a thymic protocol MRI done, and you can see on that there's not really any signal dropouts. So it suggests macroscopic fat and enhanced. And then I thought interestingly that the anterior mediastinal mass seemed to follow the right hilar node in signal intensity on pretty much all of the sequences. So I saw this at tumor board, and I said this is a really odd place to have a lymph node, but I thought it'd be weird for her to have 2 separate primaries. And I thought that, well, this could be a thymoma anteriorly. The numbers wise, that seemed odd, but this was biopsied, and the anteromediastinal node lesion came back as a thymoma, WHO type B. So I don't know if you guys have seen anything like that. Would anyone have called it prospectively? Here's the CT. One of my colleagues thought that there might have been a small amount of fat present within this, which I'm not sure if I would have called. Maybe it's just quantum model.
There's no fat in there. Nothing you could see on CT. I mean, that's.
Yeah.
You can see right there, Brian, where it indents on the right lung, sort of that pushing out. That to me is always something I don't like. Yeah, you said it was just pure thymoma, no thymic carcinoma mixed in there.
Yeah, so it was just an FNA, so a little limited, but yeah, that was a read out as thymoma type B. Yeah. Do you guys ever see any lung cancer metastases in this location?
I've not.
No, the pattern is really odd, so it would be very reasonable to suggest she has two different tumors. Yeah.
I mean, it would be theoretically possible, but I've never seen it.
Yeah, because it would be a met to the thymus effectively.
Basically,
or
exactly.
Pre-vascular. It may be with a small cell, but you'd expect to see lymphadenopathy more centrally as well.
Okay, cool. Yeah, thanks. That was my case.
All right, nice. All right, Peter. Let's make you the presenter. There we go.
Okay. So this is a chest radiograph of a young patient, 30 years old, about 1 year following stem cell transplant. And this is an abnormal chest radiograph with diffuse interstitial opacities. And depending on your level of experience, you can think of these as subtle or not very subtle. But the best way to appreciate it is if you compare it to the prior. This is more for the trainees. But if you compare the upper lobes, for example, if you take a closer look at the upper lobes, you can see there's ambiguity. If you look between the ribs, there's ambiguity of the pulmonary vasculature here in comparison to this region right here, where you can clearly see the vessels. So this is a diffuse interstitial or atypical pneumonia in the setting of a stem cell transplant. That's a broad differential. Interstitial edema usually gets thrown in the differential typically whenever people suggest interstitial opacities, but in this case, there's no curly lines, no pleural effusion, no heart enlargement to suggest edema. And here's the chest CT. So you see this kind of patchy and diffuse ground glass opacities. This came back, or this was proven to be on histopathology, PJP, Pneumocystis pneumonia, which is not an uncommon infection following stem cell transplant. But one of the pertinent negatives is no cystic change, which is cysts are commonly described with PCP. And I'm going to come back to that a little bit later, but I'll show another case of a different patient that I followed.
Peter, was this on a bronch? Was this a transbronchial biopsy, or was it a surgical lung biopsy, or?
I don't. I think it was. They did a BAL. No, it wasn't a surgical. It was a bronch. They did a BAL and transbronchial biopsy. I don't think it was a surgical biopsy.
Yeah, usually you can isolate pneumocystis on a BAL with a stain.
Yeah, they saw it on the BAL, but then they also biopsied as well. And I'm not sure. They're looking for graft versus host as well, because the patient had extra thoracic signs of graft versus host. So I think that was the reason for the biopsy.
I think one important just side note on this case is you described it as an interstitial pneumonia, and I think that terminology. And David and Howard, you guys can probably weigh in with more detail, but predates the CT era, because most of the pneumocystis stuff, a lot of it's filling alveoli.
Right, it's actually alveolar. Yeah.
And
So technically,
depending on your clinician's experience, it can sometimes, in my experience, using that term can send people down the wrong pathway.
right.
But what you're seeing, what you described on the radiograph is excellent. And, when you have diffuse ground glass, you don't really always see it, especially with DR and CR, where the computer almost corrects the contrast of the lungs. But you do, as you pointed out, you lose the definition of the vessels.
Yeah, I agree. A lot of people, I know Galvin drives him nuts when people try, like they call pneumonia or edema, interstitial edema versus alveolar edema, or interstitial on radiograph. I think most of these eventually truly do have an alveolar component, and
Right, and pneumocystis is definitely an alveolar process as well. Yeah. So technically,
but your point about the vessels is the important part. So
the cysts are pretty uncommon in pneumocystis unless you're talking about HIV.
Right, and I was going to show, that's exactly what I was going to show, is another case here to show that point. So this is a case I've actually been following over the past week, 2 weeks.
And another point, the name pneumocystis does not derive from the fact that you do get cysts in certain cases. It derives from the shape of the organism that was thought to be some sort of a parasite, a cystic looking parasite.
Right.
Interesting. I guess I didn't know that. It's like cystic fibrosis, right? That it's
cystic fibrosis
to do with the lungs.
Pancreas.
It's not cystic, it's not fibrosis. Other than that, it's a perfect name. So cystic fibrosis,
that comes from the
findings in the pancreas in infants.
Right, exactly.
But we digress.
No. And then exactly what you guys are talking about. So this is a different patient, young patient, comes to the hospital, weight loss, several months, shortness of breath, dry cough, gets a new diagnosis of HIV, AIDS with a CD4 count of less than 10. He's got these bilateral opacities and some, if you look closely, probably some cystic change. And here's his chest CT. So the dominant finding here are these upper lobe predominant cysts, and not much ground glass, but this also came back, PJP, pneumocystis. So this kind of shows this variant of pneumocystis, which is commonly seen mostly seen in the AIDS population, as opposed to the non-AIDS immunocompromised patients.
And I think that occurs because with HIV, it's often a more subacute presentation, so it's sort of been smoldering for some time as their CD4 counts start to drop. Whereas, cases you see in transplant patients tend to be sicker. I don't know if anybody else has that experience, but I don't know if that's 100% true, if that's true, but that's one of the better explanations for it, because it's the same infection in the same lungs. It's just a different degree of immunosuppression.
Right. Yeah. Yeah. I mean, that makes sense. I'm not sure exactly but I just wanted to show. So he was started on Bactrim for treatment of his PCP and heart therapy, and he came back about 10 days later with let's show both of them, with worsening symptoms. And here you can see the cysts again. Now there's this mediastinum, which is not unexpected. There's one of these cysts. Some of these cysts could have ruptured and dissected along the bronchovascular bundles and then into the soft tissues. But the interesting thing is that he has new ground glass opacities and some consolidation at the left lung base. So I'm wondering if this is if this could be immune reconstitution inflammatory syndrome, manifesting with these new opacities, just based on the timing of the start of the retroviral therapy and the treatment for the PCP. Just wanted to see what you guys think. I mean, these are non-specific findings. There's just new ground glass. But that's one thing that I was thinking about.
Yeah.
May just be the trajectory of his pneumocystis. You know,
Yeah.
as you start treatment doesn't mean that you arrest the process that day. The damage that's already there may start showing up on later imaging, but it was already underway before.
Okay.
And you said it was 10 days?
10 days, right.
I think the immune reconstitution is supposed to take longer than that, but I don't remember for sure.
Well, I looked it up and it said anywhere from 1 to 3 weeks, or
Okay.
as short as 1 week. So I guess this would be on the shorter end of the spectrum.
Yeah.
And they usually get like massive lymphadenopathy too.
Yeah, this didn't have it.
And the other thing is he may have more than one infection. So he could have a bacterial
Right.
infection, he could have
This could even be, Yep.
he could have, it could be CMV even.
could be aspiration also, because it's kind of dependent, right? Yeah.
Right.
And then one last case. So this is a case, I opened it up to read it a few days ago without looking at the history first, but you can see patients had it's a CTA of the chest, abdomen, and pelvis. The patients had a ascending thoracic aorta graft repair and sternotomy. And then the rest of his aorta is abnormal. I mean, there's a fusiform aneurysm, but there are multiple little saccular aneurysms throughout the arch. And then the descending aorta is also abnormal. And as you get into the abdominal aorta, there's another aneurysm here right at the level of the renal artery. It's partially thrombosed. And then the infrarenal abdominal aorta looks relatively spared. There is a little aneurysm here at the internal iliac artery, but there's also some calcium here. But the rest of the aorta, there's not much calcium. And then when I look back up here, there's also fusiform aneurysms or saccular aneurysms of the subclavian arteries. So given the lack of calcium, I thought this has to be some kind of vasculitis. So I opened the chart, and the patient had this surgery done at an outside facility, and they said that he had syphilis. So it's just syphilis
Wow.
aortitis.
How old a person is this?
It was actually a patient was in the 60s or early 70s. I don't recall the exact age. But they referred him to our institution for endovascular repair now for the rest. I'm not sure for the thoracic or for the abdominal aorta. The notes weren't very clear, but the other interesting thing is that syphilis usually is known to involve the aortic root. When they operated on him, they thought the aortic root was completely normal, and it looks okay to me. I measured it and everything, and then the valve also reportedly was normal, and that also makes sense. I don't see any dilatation of the ventricle, which you would expect with the aortic insufficiency. It's also interesting that or consistent with syphilis that the infrarenal abdominal aorta is largely spared, just because the vasa vasorum doesn't extend there.
Well, you know, I'm a little skeptical about this case. I wonder if he's got syphilis and Ehlers-Danlos. Is it type 4 that's the vascular type? Because though, you know, in syphilis, you're supposed to get intense atherosclerosis. They usually have a very calcified ascending aorta. And beyond that, the most common involvement is right brachiocephalic artery. So it's really more of a central process and going up into the right brachiocephalic rather than something diffuse like this.
Yeah.
And the last case I saw of really big subclavians and, you know, these head and neck vessels being so big was Ehlers-Danlos. I wonder if he's got fleas and lice.
I'll have to look into it. There was almost essentially no notes in our chart except the surgical report from the outside facility.
So they have path. You have the surgery. You have the path on the.
I don't have the path. I just have the surgical report.
I don't even know how you differentiate all these things from one another. I don't even know pathologically.
I mean, I'm not obviously I haven't seen syphilis.
So
but
I have, because I'm old, and the case I have, for one thing, they're always yellow. So if you see a yellow chest X-ray, it's probably syphilis. But they have really intense atherosclerosis. And as a matter of fact, in the early days, they would say that if you have atherosclerotic calcification that are predominantly ascending aorta rather than arch and distal abdominal aorta, it's not atherosclerosis, it's syphilis. And that was true. That would have been true when I was in training in the 70s. That was true about a third or a quarter of the time. Charlie Higgins wrote that up and stuff like that. So the point is, if you have really heavy atherosclerotic calcification in ascending aorta, that's when you should think about syphilis. This does not fit at all for syphilis.
Well, but the ascending was replaced, but I mean, yeah, but there's no so basically you're saying that there's such a lack of atherosclerotic calcification that it doesn't fit for syphilis.
That's right. That's right. I think he's got more than one thing. You may have a positive VDRL, but I think he's got a different arterial problem.
Okay, I'll have to look into it then. If he gets.
And the path would be different. So if you could have the path reviewed at your place, I think it would be very instructive, because the pathologist described this tree bark atherosclerosis. It really looks very ragged. The intima and everything like that is horrible.
Okay.
Okay,
I'll follow up.
Yeah. All right. Well, thank you, everybody. We'll continue next week. Everybody stay well and be safe.
Thank you.
Thank you.
Thank you.